first off, as a chief medical information officer at Catholic Health Partners, which includes what, some 24 hospitals, I believe.
That's right.
Uh, what are your thoughts on the recent release of the final rules for Stage 2 meaningful use?
So it's been very exciting for Catholic Health Partners. We, like many organizations, had submitted some requests relative to the NPRM, and many of the changes that were adopted in the final rule, we were very happy with. So many of the the changes were positive ones, and for example, 90-day reporting for Stage 2 was really important for us. The delay was really important for us.
Mm-hmm.
I think the government is on the right track as far as having a process by which they can reward providers that are doing the right thing with regards to electronic health records. But on the flip side, you have to allow the technology to be able to catch up with it. So one of the major issues with Stage 2 was the delay in releasing the final rule and the time that it would take for even our EHR vendors and our third parties to be able to come together and catch up to all those final rules. So the issue that we have there is you need enough lag time for development, even for the best electronic records, to be able to put all of those things into production. And I think that was a major accomplishment with Stage 2 being delayed until 2014 as it was.
Mm-hmm. Now, what is going to be the biggest difficulty with meeting Stage 2 requirements for Catholic Health Partners, do you think?
So there's, I think, a lot of challenges with Stage 2 with regards to interoperability and interfacing. So I think there's a lot of cool things that are being recommended, such as cancer registries, but not a lot of cancer registries have that ability for, let's say, a two-way interface right now. So is that going to be available by 2014? Let's hope so, but that's going to require a lot of effort with third-party integration, with same for public health reporting. Currently in our state, it's a challenge and it's something that's not possible with a two-way interface. Same with immunization registries. So the plan is to move forward with all of those things, and the hope will be that integration with those third parties will allow us to meet those measures. But I think that's going to be a challenge in and of itself. Mm-hmm. In addition, I think the other communication with disparate systems. So our electronic record, and we have not a closed system, we have an open system, but we have a lot of owned physician practices as well, and one health record between inpatient and ambulatory. So there are a challenge when a patient gets discharged from the hospital, let's say, and goes to the patient's PCP who's on paper or on a different electronic record, and making sure that information travels and exchanges properly. And that requires a lot of, again, vendors working together. And I think Stage 2 has set the bar pretty high to say we expect that vendors will work together to make sure that this communication takes place.
Okay. Now, where are you with Stage 1? Have you received government incentives yet, or are you there? Are you almost there?
So on our live hospital side, we've either attested or planning to attest through now at the end of this year for all of our live hospitals. And we've received payment for those that we've attested to already. On the EP side, the plan is by the end of this year to have 95% of our live ambulatory practices to have met measures and hopefully attested as well, knowing that there are a few coming on board late or may not have met measures because of specialty practices and other things as well. But I think we're on target. We've been working very hard at trying to meet the measures and had a high degree of confidence in really helping our providers meet the measures by knowing the types of issues that they have, for example, e-prescribing or the patient education resources. When we know that those are ones that maybe the threshold isn't very high, but as a system, we've identified the pockets where they can have a little additional assistance to make sure that they can meet the measures.
Okay. Now, as far as I know that you're currently rolling out an EMR, right? A new EMR. How is that process going? Is that there's a new platform that you're rolling out, correct?
It's going well. So we actually started the process in 2010. So our first ambulatory practice went live in January of 2010, and our first hospital in February of 2010. So
Okay.
on the inpatient side, we're about halfway through our implementation.
Wow.
And on our ambulatory side, we're completely rolled out with all our own physician practices, although in all of our regions, there continues to be some provider acquisition and new practices joining, and so we're continuing to roll those ambulatory practices out as well. So I would say it's going very well. It's great when you have everyone using the same system and it's a shared record and a patient can seamlessly move from an ambulatory environment to an inpatient environment with the same problem list, the same allergies, the same medications, and all that information at the provider's fingertips. And really, that is the big sell of a single patient record across an organization such as ours, where a patient is really having improved care because the providers have all the information at their fingertips.
Now, what is your advice for some of those more resistant providers who are really having a difficult time with kind of adapting and evolving with this new kind of system? What have you seen at Catholic Health Partners with that?
Well, I think if you look at the inefficiencies of paper, and a lot of folks would make the analogy of comparing themselves to a bank. Would you ever go in the bank and expect that a bank would use a ledger? Well, healthcare is much, much more complex than a bank ever would claim to be. And there's so much data, so much information. Paper is just an inefficient way to deal with it. So what I explain to providers is it's really not about us. It's about the patients and delivering better care by having the information at our fingertips, having the tools such as decision support that allow us to practice better medicine. I'm an internist, and I would like to think that I keep up with the latest medication, but there are so many medications and so many potential contraindications and interactions. You really need information systems to help you deal with all of that information. Mm-hmm. One of the things that we've done is integrate third-party information through UpToDate as well, so that a provider at any time can look at the latest guideline, can look at the latest package insert from a medication, and again, get all that information instantly at the point of care versus having to go onto the internet or grab a book. Of course, books now tend to be a little bit out of date as soon as they're published. Mm-hmm. So having all that information is really important, and leveraging it as a tool is what I try to encourage our providers to do.
Mm-hmm. Now, what about ICD-10? Do you deal with that at all? Are you seeing the effects of that, or what are your thoughts on that?
Well, Catholic Health Partners was geared up for ICD-10 for the implementation next year. The delay was a little frustrating for many of us that had planned for the process. We indeed are going to delay the implementation. I know there was some discussion by many organizations about whether or not they should plow ahead or not. I think, again, it gets back to the challenge of the government regulations coming out in a timely fashion that allow organizations enough time to actually implement them. Mm-hmm. With regards to ICD-10, now we're not talking just about an electronic record, but we're talking a lot about many, many ancillary systems as well. Most organizations have a lot of third-party software that use ICD-10, and that's a much larger challenge to us than our electronic health record by itself. So if it was just one vendor, I think it would be an easy process. But the fact that large organizations have multiple vendors they have to deal with and multiple resources that they'll need to pull in to implement. So I'm hoping that when the government decides, yes, it's going to be ICD-10, it's going to be ICD-11, that they're going to give us enough time well in advance to plan for it and implement it, knowing that there's a lot of complexity with these types of implementations.
Now, is it going to cost Catholic Health Partners more to, I know that was one of the concerns of a lot of providers that, they were ready for it, and with this delay, they'll end up kind of extending those costs in terms of preparing people for it, and is that a concern for you? Or?
Well, it is a multi-million-dollar transition. no question at all.
Mm-hmm.
So we've delayed the monies that were allocated for that on our budget. In the long term, will it cost us more or less? It's hard to say. I think I'm more concerned about whether or not a new standard is going to come out in the meantime, and whether the government is going to enforce another standard beyond ICD-10, and that may cause more challenges as well.
Okay. And if you could, point out one of the biggest positive changes that the EMR rollout has done at Catholic Health Partners, what would you say that is?
Well, one of our primary focuses continue to be on patient engagement. So I noticed in stage 2 that the guidelines are really intended to have a bit more patient engagement, but we've focused on this in and far away from meaningful use, which is the fact that patients that are better engaged in their health care are going to be receiving higher quality, and they're going to be happier with their health care as well. So we've taken steps to be aggressive about rolling out a patient portal, and patients can access that through an iPhone or an Android platform, and online scheduling is available, so patients can schedule appointments using those devices, using the online portal, and now we're releasing patient lab work within 3 days.
Wow.
To patients through the portal as well. Again, it's a stage 2 requirement, but we want to stay ahead of it, and the plan is really to continue to engage those patients so that they have the information at their fingertips and they're asking for it. And I think that's the exciting piece. Patients are asking for the information, and the study that came out earlier this week showing that they're even further ahead than providers are with wanting access to the information. But we'll get that level playing field and allow the patients to better engage with their providers electronically, not just in the office, but remotely as well. So we're moving forward with electronic visits as well, with a pilot that's coming up, and knowing that that patients, when they get pulled out of the workplace, when they have to get home care to visit the office, that it's inefficient, and that we can deliver care remotely in some cases, that will improve the patient satisfaction, improve their engagement, and improve the quality. So we're excited about all those pieces that surround the patient engagement.
Okay. And I guess the last question I have for you is more of a wild card, where we've been asking everybody this in light of the election coming up. Most people will say that health IT is a bipartisan issue or a nonpartisan issue. Do you think that there will be any difference between administrations in terms of what they're doing with health IT and the government funds? Do you think there'd be any change to, say, if Romney were elected, or is it something that it's pretty consistent across the board?
I think it's pretty consistent. I would contend that meaningful use won't change, because that's law. There's money that's allocated for it. I think the biggest concern that providers, healthcare institutions have is unfunded mandates. So, anytime a law is produced that is trying to enforce a standard or enforce something new, and there's not funding behind it, and again, ICD-10 is a great example. It's something that is an expectation. You need to do it to get paid, but to put it into practice is, again, for large organizations like ours and even small provider practices, is a very expensive proposition. So I think healthcare organizations and providers are probably more concerned about unfunded mandates. I don't think anything is going to happen with meaningful use. I think even with a change in leadership at the country's presidential level, there would still be a heavy focus on healthcare IT. I think I like to reflect back to George W. Bush, who during his State of the Union address actually coined the phrase for the first time, electronic health record. Most of us were saying electronic medical record, and he said it in the State of the Union address one year, and it stuck. And so it's been equally noted on the Republican side as well as the Democratic side. So I'm really not concerned about that.
Okay. Well, that's all I had for questions. Is there anything that you'd like to add that I'm leaving out at all?
I think it's an exciting time. I think we continue to leverage technology to the best that we can to improve patient satisfaction, improve patient quality, improve patient engagement, because it's really about the patients. It's not so much about the providers. We want to make it easier for providers to use the tools that are available to them. And I think, again, it's an exciting time as we have new technologies, smaller devices, and faster internet that allows us to deliver healthcare at the speed that we'd really like to, and change at the speed that we'd really like to. So again, it's an exciting time, and we're looking forward to the next few years as we continue to press forward to this new level of healthcare access.
Well, perfect. Thank you so much again for agreeing to speak with me. I really appreciate this. So this has been wonderful.
All right. Thank you very much.
You have a nice afternoon. I know that you're very busy, so thank you again.
Thanks.
Take care.